Yeah, so I am Dr. Michael Gomez. Um, I'm a clinical trial psychologist, a PhD, got my PhD at Kansas. I work a lot with actually master's level providers or bachelor's providers. And so I get the question, should I go get my PhD? And my reply to that is, they gave me a PhD. I don't know what they were thinking. That's such a bad idea that Kansas had. I don't know. So like I can do it, anybody. So it can't be that hard, right? They gave me one. So also, we have a lot of people representing. I am originally from the West Texas area of the United States because I committed a sin in a past life. I don't know what it was. Must have been something god awful, but I'll figure out what it is later. If you have not had the pleasure of being from the West Texas region, I want you to imagine what you think West Texas looks like from me saying the words West Texas. Got it? That is exactly what it looks like. It's like whatever's in your head, that's what West Texas looks like. Like guns, yeah, Ingrid, all the guns, all the guns. Horses, tons of horses, Katie. Racism, yes, we locally source in the West Texas region. Outside of West Texas, it is called sparkling racism. And so I do a lot of work with our littles. I do transition age two or older kids, but we're gonna be talking about our littles today, okay? And so since we're gonna be talking about all the horrible things that can happen to a child, I want you to think of the Kawakas. Do you see the little guys right here? Aren't they cute? Don't they look like they exist off a diet of peanut butter and hugs? They look so cute, little tiny people. Aren't they little tiny people? So, if it gets a little too grim, think of the tiny little itty bitty Kawaka, little tiny people. Okay, just they're so cute, right? And yes, they do, Amy. Once you kind of start scratching at the surface, Amy, it gets dark with the Kawakas. They're kind of like the serial killers of the animal kingdom. They like look so innocuous and they are just like hardcore, man. So, yeah, I also really like the Kawakas too. So, for there's a lot of layers beneath that onion, Amy. So we're going to do three things. We're going to learn specifically how trauma impacts this age range, like behavioral, emotional, cognitive. We'll talk a lot about development. I have a pet peeve with when someone uses a catchphrase, and I think trauma informed has become a catchphrase, so we're actually going to define it. And then I want you to walk away with some concrete things. So, like, what can I do? What treatments can I recommend? What can I, as a provider, do today, like right this second? So, now a lot of you took a child development course at some point in your career, like, undergrad, grad school, and you remember nothing from that. You don't remember Bronfenbrenner. You don't remember Adler. When was the last time you had to use Adler in your actual job? Let's be honest, okay? So you don't even remember any of that stuff. I'm going to give you the stuff you need to remember, okay? Here's the only thing you need for your job to know about developmental stages. So, there's some really good stuff like American Academy of Pediatrics has like just visuals. You can find them in any pediatrics office. And so there's a lot of stuff out there. Cali, y'all actually have a California really good stuff on this that's just like, infographics, which is all you need. But here's the thing I need you to know. For 0 to 18, there are three stages, okay? When in doubt, if you're in a higher stage and you're thinking the kid's in a lower, default to the lower when in doubt. So we're going to go through them in order. The one we're going to kind of be most in today is this one. This is your toddlers. This is your 0 to 5 kids. This is sometimes your like even mid elementary, like second, third grade kids. And we call this the egocentric. The definition of egocentric is A plus B equals me. That's many 4-year-olds and most 40-year-old men, but that is not the point of today's talk. So, my go-to example for this is I had a colleague, his son's older now, but at the time he was 4. We were in Oklahoma, holler Oklahomas, holler Okies, and there was a hailstorm because we get a lot of those there. The hail was coming in from the east side, so he went to the west side of the house, the kitchen, and his 4-year-old son, he's not paying attention, which you never want to do with a 4-year-old. He's not looking. The kid starts to run to the east section where the glass is falling. He's like, oh my God, my son's going to get shredded. But he doesn't actually go into the living room. He stops at the entryway between the kitchen and the living room, looks up at the sky, and yells, "Stop it, God." Because that's a very egocentric thing. As he like, I do my prayers every night with mom and dad. I can just tell the big guy, cut it out. I got a direct line, right? I talk to this guy. So basically, if a person is in this stage, any event is going to be interpreted as causal by them, not just bad events, all events. So you can't argue or logic them. They don't have the frontal lobe capacity yet to do that. So your move is being present and comforting. You're going to see this a lot throughout what we're talking about today. Like with PCIT, we'll talk about pride skills. That's really what it is. And those of you, I'm a huge attachment person. This is basic Bowlby and Ainsworth. Just be present and comforting physically. Cálmate, mijita, cálmate, corazón, cálmate, mijita. It's okay, mijita. Está bien, está bien. That's it. And as simple as that sounds, it can be kind of hard to do in real time. So that's why we have treatments circled around that. Okay. And so, but this is the stage you're going to be in most of the talk. Just to make sure I cover it, because you may have an advanced 5-year-old, I'm going to go through the other two. Now, as we go up, we get this is kind of mid elementary to junior high. We get concrete. A plus B equals C. Now, if you're not, none of you are in this stage currently, so in order to mimic this stage so that you know what it looks like, I want everybody in their physical space, whether it's your office, your home, I want you to look around your room, look around your office, just glance around really quickly. Okay. If you did not see it just now, it is not causal in your universe if you're in this stage. You'll see a very good, like fourth, fifth grade teacher figure this out intuitively. Miss Torres, Luis, and Malika were laughing at me. And what, Miss Torres doesn't know, and what Michael doesn't know, is that Michael comes from a domestically violent home and he saw dad beat the hell out of mom that morning before he went to school. But he's not there physically in that environment. So concretely, he's not connecting the dots. He's at school now. He saw Luis and Malika laugh. And so that's what he thinks caused it. It's the correlation equals causation. If it's in the environment, it had to have caused it. So a good fifth grade teacher will say, huh, Michael, let's go be detectives. So, hey, Malika, hey, Luis, how y'all doing? We're doing fine, Miss Torres. Did one of you tell a joke? Oh my God, Luis told like the funniest joke. Luis, would you mind telling Michael the joke you just told? Yeah, that's how they do it. If you watch like a good fourth, fifth grade teacher, they do this very step by step process to connect the dots. Like, no, they're not like, it's Luis told a joke. That's all it was. Now, again, you still can't logic them, but you can give them really concrete data. Just tell them over and over and over and over and over, and it's a repetition is a really big factor here for this stage. Also, the more dysregulated you are as a parent or caregiver, like tío, tía, abuelo, abuela, foster parent, adopted parent, then the more dysregulated they're going to get. Therefore, the longer it's going to take to get the information into their brain. So, like when I work with a 10-year-old kid, we always do a sexual health component no matter what we're doing in therapy, whether it's trauma, whether it's depression, whether it's ADHD. That's just standard for my clinic and how I train my supervisees. Oh, I apologize. I'm sorry. I'm from Texas and I work a lot in Oklahoma and Texas, and in those states, sex doesn't occur. I don't know how people are being reproduced, but according to the state of Texas, sex doesn't happen ever. But I'm hoping in California that might occur every now and then. So just to give you an example for that, that might apply to you. Obviously, it doesn't apply to Texas. Um, we teach private parts. We do anatomical correct terms: penis, breast, buttocks, vagina. Most parents are not comfortable with these words, and that's fine. It's kind of weird if they are. Okay. Now, if you're working with like a tween boy, like a 10-year-old boy, penis, breast, buttocks, vagina. Okay, say it again, Paul. And again, oh, Paul, you've only been laughing like 2 minutes. You got to laugh 3 minutes per private part. That's like 12 minutes. Okay. Now, a very good rule for this stage and the one prior to, if you are going past 10 words for a child in this stage, you've lost them completely. So, Monica, what I need you to do is I need you to go. Monica, mijita, please go to your room. Thank you, Monica, for going to your room. Now, please put your coat on. Thank you for put that. You have to do it step by step by step. When I'm working with kids in this later age range, or like a really sharp 5-year-old, then the parents will say, Ms. Vargas, that's going to take too much time. And I just have them time it. I say, do your strategy. Monica, go get your clothes on and get ready to go to Abuela's house. Time it in real time, put a stopwatch on it, then do my Miss Vargas's strategy of breaking it down into steps. And the breaking it down always saves time. Because those of you who are parents know this intuitively from having had kids. By the way, just to be very transparent with everybody on the call, I don't have any of my own children, to my knowledge. But like those of you who do have kids will get this very intuitively in the sense that if you just give them a global command or you go more than 10 words, they don't get it. But if you break it down in 10 words or less, they do. And so now the last stage, which some of your parents are in, like I work with teen moms and dads. So some of my teenagers are in this stage with their 3 year old, which is why I'm going over this. Now you're in abstract. This is your high schoolers in the college age. A plus B equals Y. Now they can go beyond me. They can go beyond the concrete. They're not really good at it though. It's like giving a 15-year-old a Maserati. They have too much firepower in their frontal lobe, but no way of knowing how to use it. And so, because their frontal lobe is still cooking, so their executive functioning is still developing. Um, so, what in this stage, you have to consequence immediately, or they don't know why you're doing it. They're like, if Nora waits an hour to consequence her 4 year old, Mom, why are you so mad? That was like an hour ago. Like it's already out of their brain, right? And in this stage too, it's already out of their brain because it's concrete. They're not in that environment anymore. They're in the living room now, not in their room. On the other hand, on this side, you actually want to almost mirror image every discipline technique. So with a 5 year old, you want to consequence immediately. With a 15, 16-year-old, you want to wait to consequence because parents, those of you who have teenagers and are on this call, first, may God have mercy on your soul. Second, you have probably figured out that if you consequence immediately, you punish yourself oftentimes. So, Roxanne, you are grounded, young lady. I don't care. You're grounded for a week, Roxanne. I don't care. For 2 weeks, Roxanne. I don't care. For a month, young lady. And then Roxanne's mom is like, I don't even like Roxanne. Right? Why am I? Now that mom is punished, Roxanne's just going to stay in her room and scroll on her phone. Now, this may be just my kind of dysfunctional background coming into play here, and I can admit that. When my mom was yelling at me as a kid, everything was fine. That was just like a Wednesday. So like she's a Mexicana mother. That's just what she does is she yells at me, right? I give her a lot of reason, and she's a saint because she didn't murder me. And she's a great person. Here's where when I was in this stage, here's where I feared my mom like a tribal god when she stopped yelling and went, Michael Daniel, I'm going into my room. I will be back in exactly 45 minutes. And at that point, Michael, I will have your consequence. I'm dead. I'm gonna die, and she's gonna kill me, and they're never gonna find the body because she's a very smart woman. And like, right, Tia? Yeah, I'm dead. Like, I'm like, oh no, she means business now. I got to listen to what she says. And so, moms get that, right? Moms and dads, y'all get that for your teenagers. So you can see how it's almost like a mirror image of this stage that we're going to be talking about mostly today. But again, keep in mind, I have teenagers who are in this stage with kids who are in this stage or this stage. So that's why I'm covering all three right now because you'll see it in a second. This is really parent work, not kid work. So now, here's some common myths I hear for kids this age range. First, they just can't do therapy. Just flat out can't do it. Second, well, if they can, it's only like behavior modification, like ABA is the only thing they can do. Or it's only things like play therapy. And like you have to have like the highest level of training to work with this, which is not true, obviously. And then like, well, they don't have like a high enough IQ to do evidence-based treatments or things like that. The one I hear a lot for CBT, which I'll show you what CBT looks like for a 2 year old today, is that kids with that are 5 or younger don't have thoughts. And my reply when I hear that is, have you ever been around like a 3 year old? They are only thoughts. They just can't organize them because their executive functioning hasn't caught up to them. So Sydney, how was your day today, Sydney? There was a bug, and I don't know why Miriam has a jacket, and Lisbeth likes butter, and Letitia said she liked me. You sound schizophrenic. And she is schizophrenic. Every single kid, 5 or younger, is schizophrenic. They also all have bipolar, they all have ADHD, and they're all psychopaths. They usually grow out of it. It's totally cool. Like it's normative. And so But that's usually what you get. So they can thank for sure. It's just the organization leaves something to, be desired, and that's fine. We can work with that. But they totally have thoughts. Now, please do not remember this. You do not need to remember this. This is not quals or comps. But I want to point out a couple of things specific to our very young kids. PTSD doesn't really follow like our younger kids very well. It has some things that are helpful though. But the one I want to focus on here, you see under intrusive symptoms, the second to last, traumatic play. Do you see that one? Okay. This is what traumatic play is not. Billy has a frog in the sandbox, which represents the womb, and the frog represents the no, he saw the Muppet movie and he likes Kermit. That's all it is. Uh, don't have to go any farther. Traumatic play is actually out of all these symptoms you're seeing here, is the easiest to spot for traumatized kids, but it doesn't look like trauma. It looks like something I'm guessing most of you have seen, but it's not trauma. It looks like autism. And so I'll give you an example. I had a kid, just so you can see this example. He would do this for 50 minutes if I let him. He would come into the playroom, get the boy doll, girl doll, hide them under the bed, dad doll, mommy doll, with this look on his face, very checked out. Dissociated is our term for that. Now, if I that looks very autistic, right? And I actually do a lot of work with autism and trauma, and even with young kids this age range, autism and trauma. This might get a little into the weeds, but it might be helpful for some of you who do that work as well. Um, Autism and trauma together is a dimmer switch. Autism that you don't have autism, but it looks like you have autism, and it's really trauma. There's no autism, is a light switch. So, for example, stemming, like stemming with your hands or your fingers. If you have autism, when you get triggered, it will go into overdrive. But it's going to always be there, no matter what you're doing. It's going to self-stimulate. But it'll go into overdrive when they see like a male because they were abused by their uncle, when they smell something, when they see a certain color. Okay. Now, if you have trauma, like my kid who saw a ton of domestic violence, and it looks like autism, but isn't, it just goes away. You can see how our healthcare system falls apart because, like in a 15-minute med check, it's just stressful. Just American healthcare is stressful. No way around it. And so, yeah, they're gonna probably be stemming no matter what. And so it looks autistic. Um, I I'm not trying. This is not a knock on child welfare. I work a lot with child welfare. They have a lose-lose job. They just can't win in any of the states I work in. And but I'll get this from child welfare workers. They'll say, Dr. Gomez, Susan has autism at home, but not at school. And I have to explain that autism isn't like my uncle's left rotator cuff. When it gets rainy outside, autism flare right up. Around the shoulder, just flare right up. Get a little, when it gets cloudy, get a little autism. No, it doesn't work like that. It used to be called pervasive developmental disorder, and that's still a good way to think of it. It's either there, like it's always there or not. Now with trauma, it just gets a little bit worse. And so now again, that's maybe a little too into the weeds. But you can see like a lot of these symptoms don't really kind of match with our five and under, right? So like distorted thinking, negative emotional states, yeah, that yeah, I guess you can kind of like square peg round hole that. But like inability to remember just your day is pretty normal for a 3-year-old. So because we were unhappy at the National Child Traumatic Stress Network with PTSD for our five and under, this was developed. Some of you may be familiar with this diagnosis, developmental trauma disorder. Um, I like this a lot for our littles because the key word in post-traumatic stress disorder is traumatic. The key word in developmental trauma disorder is developmental. These are the kids that look like they have a developmental disorder, but they technically don't. They look like they have autism. They look like they have an intellectual disability. They look like they have ADHD. You've seen these kids. These are the kids who are extremely good at social skills but can't read. These are the kids who can do math amazing but can't write to save their life. You've seen these kids. I affectionately call them our Swiss cheese children because they have holes punched in their functioning because trauma is a toxin. And so you can think of it like a toxin exposure. There's going to be holes in your functioning. The thing I like about this as opposed to PTSD is PTSD really kind of requires something that happens to you. This one, something can happen to you, but something also cannot happen to you that should have happened. You should have had a mother and father who were not on methamphetamine. You should have had a dad that didn't go to jail forever. So these absences and presences of traumas are a little bit better accounted for. Things like neglect, emotional abuse, chronic interpersonal traumas hit a little bit better. Now, I highlighted in blue the ones that are a little bit more different than developmental trauma disorder than PTSD here in developmental trauma disorder. Like it emphasizes dissociation a lot more, your inability to do a goal like getting dressed, putting on your clothes, like taking care of yourself. What I really like about this one is the decluster because it talks a lot about relationships, which I think PTSD kind of leaves out. So like I work a lot with kids with problematic sexual behaviors, and they are very treatable if you do the right treatment. But they often get in here, and there's not kind of a place in PTSD to put that. But here we would have a place for that. And so we I really like this because it emphasizes that trauma impacts your developmental trajectory across developmental milestones like speech, walking, social, emotional, everything, academic. And so it looks at how is trauma being is throwing off your developmental trajectory, and then therefore how do we get it back on course? That's it. So I like this a little bit more than PTSD, but PTSD is still not an awful diagnosis even for our young kids. It's just a lot of those we kind of got a shoehorn in, and this one I think hits this a little better and was kind of designed for our little people. Obviously you're going to be 20 and have this, but it shows up more in the age range we're talking about today. Now, just because I put it in at the front of the slide deck, I want to make sure to talk about what trauma-informed care actually means. I'm I have a big pet peeve with catchphrases. Like, do we have synergy today, Teresa? You got synergy there? Mercedes, everybody have synergy? I hate stuff like that. So we're going to define this. Here's your definition for trauma-informed care. Being truly trauma informed means you stop asking one question and you start asking two questions. Here is the one question you're never going to ask again. Lily, what is wrong with you, young lady? What is your problem, Lily? We're done asking that question. Here's the question you're going to ask now. Yo, Lily, what happened to you, kid? What have you been through? That sense of commission and the sin of omission. Hey, Lily, what were you supposed to get that you didn't? Again, most kids are supposed to get a mom and dad who aren't on drugs, or a dad who's not in prison for homicide or neglected. They're supposed to get fed and loved and cared for. They just are. That's just some stuff you're supposed to get, man. And so those are the two questions we switch to. If anyone's familiar with like Dr. Bruce Perry's work, he has a book that was co-written with Oprah called What Happened to You. This is what they're talking about. It's a wonderful book, by the way, so I would recommend it. What Happened to You, co-written by Oprah Winfrey and Dr. Bruce Perry. Also, Oprah's a national treasure. I just read whatever she tells me to. I'm just kind of a slave to Oprah right now. Just like she just tells me to read something, I'll read it. That's just how I work. And so, but that book is a really good kind of primer on this exact concept we're talking about. Those of you who work with like like I'm thinking I work with teen moms and dads who have kids in the age range we're talking about. I would recommend the following, rememberingtrauma.org. Dr. Cassie Cassell out at Northwestern, who's one of our big dogs in the national network, created it. It's a short film about a transition age youth named Manny, and there are two parts. The first part is the actual film. The second part is the film, but with expert commentary. So again, like our big dogs at the national network, like Julian Ford, Bob Pinews, Rocio Chang, and Cassie Cassell's on there. And I think it's Cassie herself who says in the second part, traumatic stress is the great imitator. Basically, trauma is supposed to look like everything but trauma. It's supposed to look like ADHD, MDD, GAD, eating disorders, headaches, stomach aches, back pain, learning disabilities, autism. It's supposed to look like anything but trauma. And so the problem is just getting it out in the open. And once you got it out in the open, you can actually address it, but it hides very well. It lives in darkness. I was at a conference in Pittsburgh, and just a guy I'd worked with in OU Med who does a lot of HIV research and pediatrics was at a pediatrics conference. It was just a coincidence, and I just ran into him randomly. So later that night, we're catching up, having dinner, and I told him this phrase, traumatic stress is a great imitator, and he says, "Yeah, that's a lot like HIV, Michael." I'm like, I'm not super familiar with the HIV literature. He goes, HIV is photosensitive. I don't know what that means, man. Here, take the human immunodeficiency virus, put it on a petri dish, expose it to light, air, sun. It withers and dies pretty quickly. It's not a robust virus like COVID. COVID is kind of a robust virus. You can transfer it through like spit or your breath. You can't do that with HIV, but once it's in you, it does a lot of damage. So yeah, that actually is a lot like trauma. Once it's in you, it can literally kill you. That's not a metaphor. Um, that's a very real reality for a lot of our adult patients who were traumatized at this age range and never had it addressed. It literally kills them. Suicide, completion, alcohol, substance use, incarceration, ACEs, for those of you who are familiar with ACEs. Yeah. I said, yeah, that's a lot like that. Once you get down to the light, it dies pretty fast. And so keep that in mind. Your kids are not gonna come in for, especially for this age range, for trauma. They're gonna come in for bedwetting. They're gonna come in for fighting, for tantrums, that's what they're gonna do. Um, sorry, this is a family I have here in West Texas. The mom came in, chiflada, flaca, mensa. That's what I was like, I gotta trauma inform this mom, man. And she did, to her credit. Mom went with me once I started breaking down. Mom had gotten out of a domestically violent relationship. And she went with me, but that was day one. That was hour one. Like, chiflada. That's all she is. Dr. Gomez, chiflada. Flaca. Mensa. And so I'm like, I love you, mom. You're so cool. You're just so fun. And she did great. She's doing fine. We had to cross. That was our first like big thing to do. Is like, yeah, I gotta get you to see, not what's wrong with her. She's not chiflada. She is traumatized, and so are you, by the way. And she did get that once I started breaking down. Now, in her defense, she thought, well, we left her dad a year ago. She's like 5. She was 4 when we left. How could she remember anything? She remembered a lot, actually. And it really surprised mom when she found out how much her little girl remembered. But we had to cross that. So this may be your first thing you got to do with any parent, and it's okay. It's fine. I'm very empathetic with them. Now, if you forget everything I tell you, I'm cool with that. Michelle will be very upset with you, so will Lana, but I'll be cool with this. This is what you need to know for any evidence-based treatment. Michelle recommended the California Evidence-Based Clearinghouse. I love that resource. I give it everywhere I go. Like everywhere I can, anyone who'll talk to me. Like, you got to see the California Evidence-Based Clearinghouse. You got to go on there immediately. And like, sir, can you please take your burger and leave? But I still told the guy because it's very important. It's such a great resource. But for there, you'll see some patterns for all evidence-based trauma treatments across the age range, from this age range to our tweens, teens, adults. And for kids, here's what it looks like. First, you have to assess in some way. It doesn't have to be a full psych eval. It can be like, we'll talk about PCIT, parent-child interaction therapy. They do an ECBI, ECBI, Iber Child Behavior Inventory, which is specific for their model. So it's not like a IQ test. Um, it's specific there, but they do that because they want to see how, like, is the treatment actually making a difference. You'll see psychoeducation, which is kind of a horrible name. I often title it orientation. This is what I did with mom. This was our psychoeducation. And she's not Mensa. I really liked it though. But that's it. That's a step where now we're in this step. Give them direct techniques to manage the stress, and often the parent, the caregiver. Direct exploration of the trauma is often done, and with our kind of like, especially if you get to the 4 or 5 year old age range, it looks very different than it would for like a 15-year-old, obviously. And honestly, we'll talk about actually how we correct those incorrect thoughts, those thinking errors. Now, if you all, again, you can forget all of this. If you want to ask one question to a caregiver, a parent, foster, adoptive, bio, grandma, grandpa, Theo, Thea, if you just want to ask one question to know if their child is actually doing evidence-based effective trauma therapy, here's the one question. Caregiver, what are you directly doing in the treatment? And here's why that's important. There's a very smart guy at Harvard who asks very simple questions that are very hard to answer. His name's John Weiss. Dr. Weiss asked the following question one day. He said, what makes child therapy work? Simple question, stupidly hard to answer. He looked at literally everything. Inpatient versus outpatient, school-based versus home-based, master's versus doctorate, it, all these things. And he found the single biggest factor for if a child gets better in therapy for kids 18 and younger. Four, ADHD, generalized anxiety disorder, major depressive disorder, OCD, PTSD, ASD, and a bunch of other things are caregivers. That's it. Probably didn't need a PhD to give you that nugget, did you? 168 hours in the week. I would see your kid one. It is arrogant and disrespectful, caregiver, to think I can fix your kid in an hour. That is arrogant and disrespectful to tell you, mom and dad, abuelo or abuela. What's more intelligent is we dump our wisdom into the caregiver's head, and they have a therapist forever, right? I usually tell therapists, we actually at my clinic we don't deal with PTSD or MDD or DTD. We deal with MUFD. Are any of you familiar with MUFD? Messed up family disorder, or FUFD, depending on the family or day you are having. And here's how you know you have MUFD is the kid walks in your clinic and you're like, hey, Grace, why are you in my clinic? Are you like funny, you're witty, you're sarcastic? I don't know why you're here, Grace. Then Grace Bio's parents walk in. I say, copy that, Grace. You never stood a chance, did you? Uh, need a parent transplant, don't you? And so, yeah, that's how. And so the caregiver being included, that's where the money is. Okay. That's where going to be our whole talk is inclusion of the caregiver. That's for this age, you might be able to get away with it with a 17-year-old. Kind of you can't, I'll be honest with you. But I might be able to duct tape that 17-year-old if the parent's not playing ball or the caregivers aren't. But with the age range we're talking about, five and under, it's impossible. One-on-one talk therapy with a 3-year-old is a little one-sided, trust me. Uh, it just doesn't work. And so the just to kind of hammer this home, there was a study done in one of the models we're about to talk about, trauma-focused CBT. It was Dr. Esther Deblinger, sorry, one of the developers of trauma-focused CBT did this. She has since replicated the following study. There were three groups. All got TFCBT, so all got better. Better was defined as symptom drop like depression, behavior problems, anxiety, and improvement in functioning, school attendance, sibling relationships, subjective feelings of happiness. That's what better and what like symptom drop and improve in functioning was defined as. Here are the three groups. Caregiver and kid came. Second group, caregiver only came. They didn't do caregiver therapy. They just made them like a coach, like a parent coach, and taught them all the therapy so they could implement it with their kid. And the third group was the old school classic one-on-one with the therapist, kid and therapist. Keep in mind these are 10-year-olds. And so 10 to 12 was the age range for this study. Now, gold medal is obviously caregiver and kid. So who do you think, though, in the chat box, who do you think got silver medal? Caregiver only or kid only? Who had more improvement and more symptom drop? What do you think? God, y'all are good at this. Caregiver only. In 20 weeks, the child never walked in to Dr. Deblinger's clinic, and they had more symptom drop and improvement in functioning than when the therapist saw the kid one-on-one, which kind of flies in the face of a lot of old school therapy wisdom. Like, I am not the important thing. The caregiver is the important thing. And so, sorry, we'll go this 2 seconds. I had uh, a supervisor really hammer this in because I wasn't really convinced of this, but my experience has now convinced me of this one central fact. Now, we're going to actually talk now about the treatments and what they look like. Okay. Now, there are more than three, but this gives you a good idea of how this works for this age range. I'm also giving you the most evidence-based ones, the ones with the most data. There's still some that are wonderful. They just don't have as many research studies or peer-reviewed trials. Like one that I would reference is ARC, Attachment, Self-Regulation, and Competency, Margaret Blostein and Christine Kenneburrow's model. Beautiful model. It just doesn't have as much research as like PCIT. So, but it's a very good model. Okay. Now, a supervisor, to the point that I was just making, a supervisor told me this when I was a student, and I did not believe until I was licensed. She said, Michael, caregivers are the solution, not the problem. They really are. I did not believe her at the time. At the time she told me this, given the caregiver I was interacting with, my reply to my supervisor was, yes, they are. Look at the thing they're doing, which admittedly is a little nearsighted, a little, a little dense on my part, but they really are. The caregivers are not the problem, they're the solution. So this is why when I'm working with caregivers, they may be like the caregiver I just referenced, like chiflada, like mom, you are my only hope, Obi-Wan Kenobi. I cannot do this without you. I need your help. You are my star quarterback. And if my quarterback does not play well, we don't go to the freaking playoffs, do we, Cowboys? Jesus, God, it sucked this year. And it's like I have their last Super Bowl win is on VHS. I got it. Like it's so hard to be a Cowboys fan right now. Okay. But yes. And this is our central tenet for everything. And again, notice I didn't say parent, caregiver. Sometimes parents are the most dangerous person for the child you're working with. We mean caregiver in the broadest sense. Foster parent, adoptive parent, huelo, huela, tío, tía, pastor, preacher, deacon, juvenile probation officer, court-appointed special advocate, guardian ad litem, teacher, daycare worker, psychiatric nurse. Like, we'll pick anyone, child welfare, actually. And so someone besides you who actually gives a crap about this kid. That's where it is. That also, think of the opposite of this, what that communicates, especially to a young child, that there is no adult who really cares about you, how horrible that feels and damaging that feels. And so one of my mentors would say, I think a lot of parents love their children very much, but they don't know how to love them well sometimes. And I think that's kind of what we're trying to drive at here. The therapies we're going to be talking about is how do you love your child well? I know you love them a lot. How do you love them well? And so the first one I'm going to go over is parent-child interaction therapy. Now, I I had a mom I was doing PCIT with. Thumbs up if you're familiar with PCIT or PC Cares. Love it. Cali, y'all represent for the PCIT world. Yeah, love it. So y'all have a really good contingent out there. I'm in Texas. It's just me in West Texas, dude. It's me and one other doc, and we're just trying to hold the line like a zombie raid. And so it's rough, man. It's like my kingdom for five California PCIT therapists. My kingdom. God, it's horrible out in West Texas. But I was doing PCIT, parent-child interaction therapy with a mom. And in mom's defense, that her 5-year-old had been a demon at kindergarten that day. Mom can't even get out oh, nice job, Catherine. Yeah, go Alameda. And so mom couldn't even get out a labeled praise. She was that frustrated with this little girl. And I understand why she was. So I pause the session. My co-therapist goes in to stay with the kid. I pull mom into the observation deck. I say, Mom, what's going through your head? And she can barely get out of it. Like she just is so, and I cannot believe she's just gritted teeth, just mad at this kid. And I say, Mom, I think what you're thinking is that the symptoms go down for your daughter and you will like them more. That's exactly what I'm thinking, Dr. Gomez. No, you like them more and her symptoms go down. And then she gave me the middle finger and walked out of the clinic. And that really actually did happen. Yeah, yeah, that that really happened. Actually, Grace, they do a version of this. This never goes away because this is basic attachment stuff. They do this for couples therapy. But they like the couples version of this is by the way, I just to be very clear, I do a lot of child therapy. I do a lot of individual therapy with children with adults too. I don't do any couples therapy. Because I suck at it. And that's at least what my supervisor at the VA said when I was there doing the rotation for the couples and marriage clinic. Because I was 5 minutes in the session, I look at the woman and I say, "Oh my God, you've been with him 5 years, been with him 5 minutes. He's an a-hole. You must be a saint. This guy sucks." And my supervisor said that's not effective couples counseling. And I asked him, we can agree though that he is an a-hole, right? And he's like, yeah, we can. That's all I needed. That's all, yeah, that's all I needed. But like if those of you who are interact in that role, like with couples, first, God bless your soul, because I can't do it. But they'll ask you a question and they don't really give a crap about the question. What they care about is how you answer it. So, Jeanette, how did you and your partner meet? They don't actually give a crap how her partner met. And so here's what they're looking from. Thank you, Anna. I agree too. Here's what they're looking from Jeanette. Jeanette, how'd you and your partner meet? Oh my God, it was like the craziest thing. We were at this party and we were in like Santa Monica and that means like, okay, we're probably going to be okay. Versus, hey, Jeanette, how'd you and your partner meet? Party, Santa Monica. Oh no, that's bad. PCIT kind of does that. Well, the way we start this off, and thank you, Maria. I appreciate the validation from the group. Is they have the parent play with the kid, like with blocks or colors. We don't actually care what you're doing. We don't care if you're building the puzzle. We're looking at how you're playing. And so this is what how we do this. So the first we have two phases. On average, it's about 15-ish sessions, but it is not a session-based model. It is a skills-based model, meaning you have to graduate from the skills. You have to do the skills to competency. And so the shortest I've ever done PCIT as a therapist is 8 sessions, and that family was amazing. They just flew through. The longest was 32 sessions. This was a child welfare, like they like referred him from child welfare. Basically, if you don't finish PCIT, you don't get your kid back. That's what child welfare said. And so dad had done the like parenting groups and had just kept abusing and neglecting his kid, and he thought he could just wait me out. And he wasn't doing any of the skills, any of the homework. And I said, Mr. Smith, I will be here until the star death of the sun or until you reach mastery criteria for child-directed interactions. Like my patience is eternal. And he did get it. Like by session like 13, 14, if we took out all the sessions he just like, dragged his backside, probably it took about 18, right? So it's within the range. Now, there's the two phase. They actually have a third phase I'm going to talk about, but the two phases are child directed and parent directed. Now, child directed is our attachment phase. Parent directed is our Skinnerian phase, our BF Skinner commands discipline phase. And the rule for the first one is attention is to behavior as oxygen is to fire, right? If kids don't care where the attention comes from as long as they get it. Now, it is an empirical question. Um, that like um excuse me. So can we just like, do that like discipline part first? I mean, can we, I mean, do we really have to do that like attachment stuff, right? Like that's kind of a legitimate empirical question, right? Like, hey, Miss Powell, do I really need to do all that attachment crap? Can I just get the kid to listen and I'll go back to the attachment stuff? No, you cannot. And here's why you can't. Dr. Sheila Iberg, who developed this model, did a study and she had to shut the study down. Here's why she had to shut the study down is if you switch the first second phase and you put it first, like you do parent directed, which is more of our command discipline, classical behavioral like therapy looking stuff, and you don't do so basically if you do Skinner before Bowlby, here's what it looks like. Javier, sit in the chair. If you don't sit in that, oh my God, this is bad. And these aren't even abused kids. We have to shut the study down. That's what it looks like because it's not that the symptoms go down and you like the kid, it's that you like them and the symptoms go down. That's what we're trying to do. I have this from more moms than I can count, and I work a lot with child welfare, so keep that in mind. I will get the following. Some of you may have heard a variation of this. Dr. Gomez, um, love my boy, but I do not like him, Dr. Gomez. And my reply to that is, Miss Scott, I understand that. We don't like people who yell at us, Miss Scott, who throw things at us, who cuss at us. Jill, I think I'm a fairly affable man, but if I started cussing at you and spitting at you, Jill, I'm pretty sure you wouldn't like me. That is not a Miss Scott problem. That is not even a mom problem. That's a primate problem. Primates do not like aggressive primates. That's just evolution. Okay? So we gotta get you to like your kid a little more. Now I'm gonna swing back to the other bullet points here, but just so you know what CDI looks like, because what we're finding with our abused kids is CDI is all you might need. If anyone's familiar, thumbs up if you're familiar with PC Care. PC Care is developed by my mentor's mentor, Dr. Robin Gerwich, and it's basically just CDI on steroids. And they're finding that this is very good frontline for abused kids, neglected kids in this age range, because they're finding once you do CDI or PC Care, you might not need to do parent directed. You might not need to do a timeout sequence or like, like a sticker chart. It's amazing how much your kid listens when when you don't hate them and they don't hate you, right? Now, this is very behavioral. This is very like concrete in the pocket. So for classic child-directed interaction, and yes, Crystal, we can send you these too if you need them, is we have do skills and don't skills. Now, the way this works is we will observe you for 5 minutes playing with your kid with like just basic toy, not like a hammer or superheroes, but like blocks. colors, that those plastic kitchen food. And what we're looking for is math for you to graduate from CDI to go to the next phase. You need to do in 5 minutes 10 labeled praises, 10 reflections of language, 10 like imitation's more a subjective one, 10 descriptions, and we'll talk about the E in a second. So here's what so we're gonna go through these one by one. And so good job, Catherine. Catherine, good job letting everybody know that Alameda County is doing some wonderful things with PCIT right this second. Labeled, right? Reflecting language. I'll have a ball. You have a ball, sweetheart. I like playing with a ball. Yes, you like playing with the ball. Yeah, reflecting the language, imitating, again, appropriate behavior. You're drawing a dragon, I'm drawing a dragon. You're on the floor, I'm on the floor. You're playing with Lego. Keep in mind, I work with we do this a lot with child welfare. That we'll see a mom just like, oh, you're gonna color, I'll play with blocks. And like, no, mom, you're coloring too. Now, the scribe I usually say for later because it's a little bit harder. It's not as intuitive for parents. I had a grandpa. Those of you who work with foster care, grandparents raising grandchildren are the largest demographic of foster parents in North America. And so he got the first three, but number four, he was doing a little bit. It was hard for him. So I said, "Hey, Grandpa, are you a football guy?" I was like, "Yeah, Boomer Sooner all the way." All right, I can work with that. So do you watch football? Like, yeah, I watch NFL every Sunday. Okay, you've never seen the sports announcer like ESPN, CBS say, "All right, Mahomes takes the snap, he drops back, and everything's good. It's all good. Everything's fine. Nothing more to say." No, all right, Mahomes is on the 20. He takes snap back, drops to the 15, and the pass is complete. And they're at the 40, the 50, the 6. Do that. And so his son, his 5-year-old grandson, all right, Billy, I want to be ESPN today. He's like, okay, Papa, ready? And I said, okay, we're going to start playing. He's like, all right, let's start. Billy Smith has the red block in his right hand and is putting that red block on top of that blue block. Such a good job using the blocks, Billy Smith. And the kid loved that. It was so adorable. I was like, you nailed it, man. Good job, brother. And he did. That was the kid loved it, right? Um, Part of the way this works, this is not a trauma thing or a therapy thing. This is just a primate thing. None of you have ever come home from work and said, you know what? I'm getting too many compliments over there. Just too positive over there at CalTrin. Too positive. I can't work there anymore. Everybody's too happy. I gotta quit. You've never had that day. You never will have that day. But yeah, no one's ever gotten that. Now, keep in mind, way back in the day, these used to be called the drip skills, DRIP, until we worked with postpartum depression moms in the late 90s. Because here's what that looks like. Lisa, you're sitting on the chair, Lisa. You have a red block in your right hand, Lisa. You're doing a good job. Play. Nope, 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 no, that's not gonna work. So we're gonna fake it till we make it. Gonna be enthusiastic. Also, keep in mind where the E comes out from my population and clientele is I work with parents who are recovering from addiction, like oxy, meth, cocaine, like they're former addicts, and you can see how, even if you're like if you've gone through physical withdrawal, that stuff doesn't go away after like a month or two. I mean, you're still like jonesing, still hurting. Addiction and recovery are hard. So that's where I usually have to pull in the E as my parents who are in a recovery from substances or alcohol. So keep in mind that's what. Now you see the don't skills. In 5 minutes, we don't want you to do any commands, questions, or negative comments. So Miss Acevedo, you're saying I can never ask my boy a question. Is that what you're saying, Maria? No, Mr. Gomez. I'm saying for 23 hours, 55 minutes of a day, you can ask as many questions, give as many commands as you want to your son. It's the 5 minutes of special time that I'm assigning you each night. By the way, that's the real-time load for PCIT. An hour a week at the clinic. We can also do it tele. We got iPCIT, Internet PCIT, so you don't even have to leave your home. By the way, shout out to Los Angeles County. LA County, which I work a lot with, had to do that when ice hit the ground. Parents couldn't come. They were scared. So they just did iPCIT, tele PCIT. They never left their home. Worked fine. Very good job. I know a lot of other counties were doing that. I was just extremely impressed how fast LA County, man, man, those guys are G's, dude. And so the now 5 minutes a night, you do special time, one-on-one time with your kid. Now, keep in mind, every week we're going to coach you. The first 5 minutes of session, we're going to have you do non-directive play and see how you're doing on these skills. That's why one family finished this whole model in 8 sessions and one dad finished it in 32. Because it doesn't matter like how many sessions you come to. So to kind of drive this point home, same guy that I talked about, Dr. John Weiss over at Harvard asked the basically a question of what makes those parent groups that a lot of our child welfare parents get sent to, what makes them work? Because some of them are absolute garbage. Some of them are amazingly effective. So what separates one from the other? And what he found is that it actually isn't an evidence base. What it is direct practice, like like this. So in PCIT, we do direct coaching. Incredible Years does video scenarios. PMT Oregon model does role plays. Anyone who's familiar with Love and Logic, they do role plays. So Love and Logic would technically meet criteria for an effective like parenting strategy, like group for our kids in child welfare. And so because how fast can a caregiver screw up a labeled praise? Lori, thanks for throwing out the trash. I don't know why that was so hard. Lori, Jesus. Um, One of my teenage patients took took the caregiver about 4 weeks to learn labeled praise, but she did. And she walks in, she goes, Dr. Gomez, I figured it out. What'd you figure out, ma'am? Praise and shut up. Yeah. I'm actually, yeah, so for a month we're trying to get you that through your and she did fine after that. She got the rest of these fine. But that was really it. And so also keep in mind, parents when they report to you, it's not that they're lying. Often we think we're doing better. So I had a mom have a 4-year-old boy, very disruptive. In session one of PCIT, I said, what do you think is the biggest problem you have with your son? And she said, he says no a lot. Do you think you say no a lot? Because that's a negative. No is a negative comment. She goes, I don't think I say no a lot. All right, folks, in the chat box, just guess how many no's do you think this woman said in a 5-minute coding period? Just put it in the chat box. What's your guess? How many the no's? Amy, Lyle, you are so nice, Adrian. All of you are so nice. All right, ready for the answer? 72. 72. Yeah, it was like a symphony of no's. Like, no, 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 no. Thank Jody got close. Thank Jody. No, 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 no. There was no easy way to give that feedback. She's like, really? You want to see? She's like, no, I'm good. I believe you. Yeah, right, Desiree, right, Crystal? And so she did better. She got less than 72 no's next week, and she improved. But yeah, now here's the reason for the don't skills. What I usually say for the don't, because some parents are like, again, keep okay, I probably should have said this earlier and I apologize, but I'm not trying to call out any particular ethnicity or background, but I was raised by like my Mexicano tios, my mom's brothers. And two of them are like that raised me were originally from Mexico. They grew up there. And so even to this day I'll say, "Hey Theo, do you believe in Theo like ángeles, diablos, curanderos, brujas?" Yeah, mijito. All that's real. Okay. What about therapy? Oh no. Cool. I'm like a hoodoo man to my family. They think I do hoodoo all day long. That's what it's like being me in my family. But they believe in all that other stuff. And so I get that therapy is kind of a hard sell. So point, my Mexicano deals, they just should listen, right? They just should listen. They speak when spoken to. I get that. I grew up with that. And so I usually have to tell a lot of my families, BIPOC cultural differences, immigration history or not. I'll usually say, especially when I'm talking about the don't skills, there are two types of children in the world. My blessed saint of a mother had the misfortune to have both types of children. When I was growing up, my brother, my biological brother, would get in trouble. My mother would say, Mark Anthony, you are in a great deal of trouble, young man. And my brother would say, I'm sorry, Mom, I'm gonna go punish myself. He's the first type of kid. I call them a stick kid, a vinegar kid. I, however, am the other type of kid. So at age 8, when my mom would say, Michael Daniel, you're in a great deal of trouble, young man, I'd say, oh yeah, Mom? Get ready to hear the rest I did, man. You about to be living, Ma. And that was me at 8. And the fact that she didn't murder me makes her a saint. Okay. By the way, parents on the call, if you have the second type of kid currently, first, I apologize for on behalf of my brothers and sisters. But second, we do grow out of it. Mid 30s at the latest, I promise you. And also, I still call my mother to this day. Mom, I'm sorry. Mijito, what happened? August 1998. Like the records are still, but I'll pay for the property damage. I'm so sorry, Mom. I still call her with those with apologies, and you'll get those probably in 2040. Promise you at the latest. Yeah, mid 30s, Haley. You'll be fine. They'll be fine. Don't worry about it. You'll just have some neurological damage, Haley, and maybe some like kidney damage probably too. But you'll be fine. Don't even worry about it. And so yeah. So for the first type of kid, you don't even need PCIT. For me and my brothers and sisters out there, if you give us a command, um, then we're gonna fight you, right? Right? There's like, because this never goes away, by the way. So just to give you like an example from my adulthood, my dentist in Oklahoma City would always chew me out. You didn't floss, you didn't do this. So before my cleanings, I would eat onions, garlic, and Oreos. Oh my God, like dance for me, puppet. Dance for me. Now, my dentist in Rhode Island figured me out like week one. He's like, yo, son, do you want to know the real way to floss, dog? I shouldn't even be saying anything about this. It's just flossing. But I'm like, oh my God, I want to learn. I want to know flossing. Because I am a honey kid. I'm a carrot kid. Commands don't work for me. Also, questions. I'm from Texas and I work around the South. Holla, War Eagle, War Eagle. And so I work like in Alabama and places like that. And I call these Southern commands. Lana, honey pie, sweetie child, would you mind handing me that? Right? That's how they sound, right? And so when my mom would ask my brother, Mark, would you mind taking out the trash? Sure, mom. Me, Michael, would you mind taking out the trash? Yeah, I mind. Again, that was me at 11, and the fact that she didn't murder me makes her a saint. Yeah, and we talked the negative comments, like no, like that just sets up a dynamic for they're gonna like defy you. And so we focus on this a lot for our abused and neglected kids. Now, those of you who might be familiar with PCIT, we're trying to get rid of the timeout sequence basically that PCIT has. We're trying to de-emphasize that for traumatized kids. For general population, you can do what you want. So Dr. Robin Gurwitch, who created PC Care, love Robin, she's my hero. They have now are trying to replace the timeout part, like the more. I'm also going to just be very transparent with everybody on the call. I do a lot of work with autism, IDD. As Michelle said, I'm one of the co-founders for what used to be the Trauma and Autism Work Group at the National Network, now the Trauma IDD, Intellectual Developmental Disabilities Work Group. All three co-founders, me, Dr. Peter D'Amico at Columbia, Dr. Dan Hoover at Kennedy Krieger, came up in this like working like residential treatment, inpatient psych, where we had to do restraints on children. I never want to do another basket hold. I never want to do another restraint or seclusion for a child ever again in my career. It disgusts me. I get sick and not metaphorically. I get a nausea response now if people like you have to do a restraint. I did so many. It just left such a bad taste in my mouth. I'm not saying if you're doing those that you're a bad person. I'm not saying that. I just have a visceral like nausea reaction anytime I have to think about doing some like a restraint on a kid. So, because I work a lot with traumatized kids, this is sometimes a re-traumatization of them. And so what we're trying to do is de-emphasize that like timeout sequence and go to something called trauma-directed interactions. It looks a lot like TFCBT, which we're going to talk about in a few seconds, like relaxation skills, the cognitive triangle. Even for an age range like four, like 3, 4, 5, it even looks like that. So we're trying to replace that out to give coping skills rather than like you got to go sit in a timeout room for 2 minutes. Because you can see how this triggers a kid who was locked in a closet, right? Or even a kid who wasn't locked in a closet, like a kid with just basic trauma. So we're PCIT is moving to that, and I'm very happy about that move. It's been a while coming, and they're really making strides on that. One of the last things I want to talk about before we move to the next one, just for sake of time, the reason I spend so much time on PCIT for this age range, it used to be 2 to 7 or 2 to 8. Now it's 12 months to 12 years, given the modifications PCIT has done over the last couple of decades. They also have data with kids with autism, intellectual disability, FAS, that it works with these kids, especially the CDI part we've been talking about. The reason I'm talking about this in this conversation is PCIT is one of the only treatments that works for physically abusive or neglectful caregivers. Meaning, if you have physically abused or physically neglected your child and you're in child welfare purview, if you do PCIT, you don't abuse or neglect them again. UC Davis, holla out to my Davis crew. has done a couple of these studies on in your state. Arkansas has. My alma mater, University of Oklahoma, did the original studies. Dr. Beverly Funderburk, one of the co-developers of PCIT, she works directly with Sheila, and Dr. Mark Chaffin, who was our implementation scientist at the time there, developed the study. And here's how this, I was part of this study. This is where I learned PCIT at Oklahoma. Here was the study. Dr. Chaffin and Dr. Funderburg were very smart. They said, don't give us your first time child welfare moms and dads. We want those moms and dads who have so much child welfare interaction and removal that they get a punch card because on the 10th removal, they get a snow cone. Give us those guys. And they did. So we had three conditions for the study. All three had, that was all who was in it, like your revolving door parents, right? Y'all know these people. Here was the conditions. Condition one was control, just business as usual. Condition two was we call wraparound. I grew up in wraparound. I came up in wraparound as a therapist. I call wraparound the Oprah Winfrey approach to therapy. You get a therapist, and you get a therapist, and you get a therapist, and everybody gets a therapist. Yay! Yeah, that's what I call it. I'm not knocking it, just saying that's what it is. And so now here was condition three: clean UAs, housing, job, PCIT, and that's it. Now, did what's called a survival analysis, a survival analysis statistical Hunger Games. May the odds be ever in your favor. Basically, if you are in the analysis and you like whatever you're doing along the time frame and you come back in the child welfare purview, like you got your kid back and now you're investigating again and your kid gets removed, you drop out of the analysis, means you failed the analysis. So, like again, statistical Hunger Games. Now, they followed these families 950 plus days. Here are the results for each of the three conditions. Condition one, no change. They kept coming back. I think it was like 6 to 9 months on average. They would come back into child welfare purview. Condition two, the wraparound approach, same business as usual, 6 to 9 months. They came back. No change. It was exactly the same as condition one, the control. Now, condition three, PCIT, clean UAs, job, housing. They followed them 950 days, and those parents did not come back into child welfare purview. They weren't abusing or neglecting their kids, and which was pretty dramatic. Now, the wraparound kind of surprised us, but here, wraparound isn't bad. Here's why it didn't work. The easiest way I can explain why condition two, the wraparound didn't work, is the following. Y'all had a 3-day weekend like a while back. Um, and you'll have one coming up for Labor Day. And some of you are gonna say on that Thursday before your 3-day weekend, I'm gonna clean the kitchen, I'm gonna clean the garage, I'm gonna rearrange my shelves, and you get none of that done, Jasmine. You watch Wednesday again for the fourth time in a row, okay? And you get nothing done, okay? Now, some of you may, it's a great show, by the way. Some of you may be, a little more strategic and say on that Thursday before Labor Day, you'll say, I don't care what the heck happens, man. That closet is getting clean. That's it. And so that's what's happening. And so Irma cleans her closet by Saturday evening. Sunday, she can start on the garage. So think of it this way. Think of the families you have where the caregiver is keeps coming back into child welfare purview. These are not put together caregivers. They're like in addiction or they're getting over addiction. They have their own trauma, usually intergenerational. So if you give them wraparound, that's like giving a buffet to someone who was starving. It shocks the system and they do none of it. They throw it up. So we think wraparound works well at the end, like after they've done stuff like PCIT, clean UAs, housing, things like that. And yeah, actually, that's the problem, Catherine. So for Alameda, that's one of the things we recommend is like the parents will either have to have a bridge parent for Alameda County, like meaning the foster parent is doing PCIT, teaching the bio parents. And as they go towards reunification, they need more time. They just need more time. Again, not a lot, like 5 hours. Like we don't need them to stay overnight. We just need them to have like an hour a day, Monday through Friday, to be able to do some of this homework, right? We're finding only 5 minutes a night is or a day is what we need minimum to make PCIT work. And so condition three, you just do bare bones minimum, clean UAs, housing, job, PCIT. That's like I'm gonna give you some crackers. You haven't eaten in 3 months. I'm gonna give you some crackers so your system can start digesting it. Um, Thumbs up if you're a CASA or you know what CASA is, Court Appointed Special Advocates. Um, so I was a CASA. I was a CASA here in West Texas. I'm a huge fan of the program. I do a lot of training with CASAs. I worked a lot with Oklahoma County, Lubbock County, Cleveland County. I'm a huge fan of CASA. Um, and so when I was a CASA, I would go to court, and here's what I would hear: 5-year-old boy physical abuse charge for the father. Your Honor, I was just disciplining my boy. And my thought as a CASA was, you're a lying sack of crap. You broke your 5-year-old's nose. You're trying to avoid jail time, man. Now, I'm not saying that that never happened, but I did CASA. I was a CASA long enough where the more disturbing conclusion came about while I was doing court-appointed special advocacy is that, oh my God, you believe that. You actually think punching your son in the face is discipline. So again, keep in mind we did this in Crimson, Oklahoma, like one of the reddest states in the union. And the child welfare higher ups and the criminal court higher ups, because these guys are often involved in criminal court, were saying, no, they're just piece of crap parents. And what we said is maybe they just don't know how to parent. Maybe they're not evil people. Maybe they just have no idea how to parent, which made sense after having done CASA for so long. Like, yeah, I think maybe you just don't know how to parent. So one of the moms, she had one kid terminated the rights. She now had two kids. Both were under threat of being terminated if she didn't complete PCIT, which is pretty heavy on me as a therapist. Mom went into foster care at 5, aged out at 18, had her first kid at 16. Do the math. And see, that's right, Tia. And so we're trying to do praise. That's the first thing we start with. Labeled praise seems real easy. Mom is having a hard time. We are on like session 3 and she cannot do labeled praise. So I pause the session, I pull mom into the observation deck and say, Mom, what's going through your head? And she's like, I can't freaking do this. I can't do this. I said, I know this is difficult for you. Why do you think you can't do this? And she says, I never got it. I say, Miss Smith, I believe you 100%. I just want to make sure I'm hearing you correctly. You are saying in 18 years of childhood, growing up in the foster care system, no adult had ever told you a praise. Yeah. I said, that's the saddest thing I've ever heard in my life. Would you like to give your son that gift? So I'm freaking here, Dr. Gomez. I can work with that. And she did great. But we had to make it just a little bit simpler. Like Tia said, it's learned behavior, so let's help them learn. So we did what's called line feeding. So I had a little like bug in her ear and I was coaching her. I said, instead of saying mom, say a labeled praise. I just had to do it a little more concretely. So mom say, you're playing with the blocks nicely. Sugar, you're playing with the blocks real well. Good job. Now say, I like how gentle you're being with the toys. Sweetie, you're being really good with the toys. Thank you. Nice job, mom. 2 for 2. That's it. Our parents, you will get a parent bowing up to you. You will get that. Like, you don't know my life, Esmeralda, you don't know my life. You'll get that. But what you'll get more is a shame spiral. You could see that mom about to fall into a shame spiral. I don't need you to be more shamed. One of my colleagues says, here's the difference between guilt and shame. Guilt means I made a mistake. Shame means I am the mistake. You're not the mistake, mom, I promise you. You'll often hear me tell my caregivers, kids, patients, the world isn't crazy, you are. Sorry, like you aren't crazy, the world is. Like there's nothing crazy about you, but the world is pretty crazy right now. I think got a pretty good argument for that, don't I? Uh, pretty good argument. You're not crazy, the world is. Yeah, you're just a reflection of what you grew up when. Does it make it okay that you hit your kid or spiral fracture their arm? No, it doesn't. Um, that's not what we're saying. So now, just to move on, this is the age range goes 0 to 5, CPP, child parent psychotherapy. And we talk about learning the language of play. I'm going to show you one of our people at Arkansas. We have a really good team over in Arkansas. You have some great teams in California, by the way. I'm going to show you a video of what CPP actually looks like. Okay, everybody ready? Here we go.
Child Parent Psychotherapy, or CPP for short, is a therapy for children birth through age 5 who have experienced really scary, dangerous, or violent things. Things such as child abuse, so physical abuse or sexual abuse, or car accidents, or even experiencing things like being in a fire or a tornado. CPP is evidence based, meaning that there is a lot of research behind the effectiveness for using this treatment with young children and families. We know that CPP is effective because of the research that we have. So, treatment is conducted on a weekly basis. So, children and families are seen by a therapist for weekly sessions. As part of the treatment, children and families are seen together. So, one child and one caregiver may be present. CPP really aims to build skills within the family and improve the relationship between the caregiver and the child, and also to help the child heal from that scary, dangerous, or violent experience they might have had. CPP is wonderfully powerful and effective when in the hands of a well-skilled therapist to be able to really help these children and families learn.
In CPP with children, it allows us to speak their language and the language of play. It helps parents to tune in, become attuned to what's going on in the present moment and what's in the room. It helps us to align with children in their point of need. And it also allows children and parents to continue to grow. It kind of restores and heals and allows children to get back to the business of being kids. One child really sticks out in my mind when it comes to CPP. It was a very young girl who had some really severe panic attacks, had difficulty when parents left the room. Through the process of CPP, she was able to use toys to just kind of convey what was going on the inside. And as she played, and the parents played beside with her, they were able to communicate in ways they weren't able to before.
We find it to be tremendously useful and helpful and healing for children to be able to speak what's been unspeakable before, or show through their play what's been unspeakable before, so that they can begin to heal and move through that traumatic experience.
All right, my crew over at Arkansas, my Arkansas crew. Dr. Alicia Lieberman is the developer of this. Good job, Kat. Yeah, Catherine's on fire today, man. Yeah, we love CPP at the National Network. I'm a big fan of it. Um, it's for younger, it goes down to zero. So if you have, I said PCIT goes down to 12 months now. If you have a 6 month old with trauma, this is what I'm giving. Honestly, if you have a 4-year-old, I'm still going to kind of default to CPP. There's only two downsides I've ever heard of CPP. One is it's not available. So I'm in West Texas and we don't have any CPP places. California, though, y'all have an advantage because y'all have a pretty articulated CPP network in the West Coast. And so usually not super far away from that, but that depends. Like NoCal, there may be a little couple, spots that may be a little harder, but it's that's it. The only other one I've heard is that it kind of is a long time. It's usually a year of treatment weekly. It can be shorter or longer, but it's really good stuff. It was originally created for domestic violence survivors and poverty, like homeless moms. And so the way it works is you learn to speak play just like you learn to speak Spanish or Korean or Farsi. And so, and this is how you start metabolizing the stress. So speaking play rather than just have to speak out loud. And so you saw some examples from some of our Arkansas team of how they use the toys to be the tool of speaking the play. Now, the really beautiful thing about CPP is because it has such a hard focus on both parent and child, there's really not a division between the two. They're kind of seen as a unified client. This is really helpful for intergenerational trauma. I have families who have sexual abuse going back to the American Civil War, and that is not an exaggeration. And so you can see how trauma impacts, you don't even have to go that far. American slavery, Native American genocide. Um, I'm in Texas. Technically, there used to be Mexico not that long ago. And so you wouldn't know that going through West Texas, though. So there you can see how this could be very helpful because I do work a lot with families with intergenerational trauma. Keep in mind, I came from Oklahoma in my training, where we work a lot with Indian country, Native Americans, Alaskan Natives. And so this has been very powerful. Um, it's again solid evidence base here. And one of the cool things I really like is it's very easy to incorporate culture, spirituality, ethnicity, diversity, because there's not like a standard set of toys. PCIT doesn't have a standard set of toys either, but CPP really doubles down on this. And like, if you have toys that are more specific for your culture or your family, use them. And again, it is like 50 sessions, like week to week, but keep in mind we're often dealing with like four, five, six generations of trauma. I think it's kind of warranted, but it can be a big ask for some families. I think honestly, what I've seen on the ground is if a caregiver starts CPP after a couple weeks, they kind of like, oh, this is helping. They do feel the help there. It's just kind of getting them in the door. That's the only thing. But again, that everything else, I really have a positive opinion of CPP. The data supports it. It's such a good treatment. And again, it does look a little PCIT-ish, but you can see from the Arkansas team how they're doing something a little different, right? I actually with 0 to 5, I kind of lead with CPP. My kind of CPP, PCIT, TFCBT is kind of my algorithm. I kind of go in that order. It just depends what's available in your community. And also what you can see how 50 sessions of therapy versus 15 in PCIT might be more attractive. And these are not mutually exclusive. These work very well together, the three treatments I'm talking about today. So I've seen families do 15 sessions of PCIT, then be very open to doing, I'll do those 50 sessions with Miss Pal. Like, yeah, I'll get you signed up with CalTrin and our, ECI network. We're good to go. If you want to learn more about it, feel free to access their child's parent psychotherapy website. It's great. I love it. Huge fan of CPP. Now, to finish off, we're going to talk about TFCBT just for sake of time. Like we talked about, young kids actually can think. Now, do you want to see what CBT looks like for a 2-year-old kid? Do you want to see what cognitive behavior therapy looks like? All right, cool. All right, here we go. All right, let me get the video set up. Not that one. I'm going to that one. This is the one I need. All right, this is the best CBT I've ever seen. Kids about a little bit over 2. And here's CBT. Ready? It's cognitive behavior therapy for a 2-ish little kid. Here we go.
In your potty. Poo poo in your potty.
We gotta tell mommy when you need to pee. Tell mommy when you need to poop. Tell mommy when you need to pee. Tell mommy when you need to poop. When you pee pee.
On your potty.
We gotta poop poop.
On your potty.
We gotta pee pee.
On your potty.
We gotta poop poop.
On your potty.
You gotta tell mommy when you need to pee. Tell mommy when you need to poop. Tell mommy when you need to pee. Tell mommy when you need to poop. We gotta pee pee.
In your potty.
In the potty, gotta poop poop.
In your potty.
In the potty, gotta pee pee. In the potty, gotta poop poop.
In your potty.
Tell mommy when you need to pee. Tell mommy when you need to poop. Tell mommy when you need to pee. Tell mommy when you need to poop. And then you get a prize. And then you get a prize. And then you get a prize. And then you get a prize.
Yay, Janaea! Everybody give little Janaea a hand. Yay, Janaea. She is so cute and adorable. Okay, a few things to that clip. First, that is the cutest stinking kid I have ever seen in my life. And I will have words with anyone who disagrees with me. That just is a cute kid, right, Rachel? Second, cognitive behavior therapy is grounded in the cognitive triangle. Think, feel, act. I didn't see any triangles. I didn't see any worksheets. Why is that, CBT? All right, Red, let's go through the list. Did you see any actions, folks? Thumbs up, yes. Yeah, told a lot of actions. Sorry, Nitzia, for that. Now, did you see any emotions? Yeah, yeah. Thank you, Elizabeth. Yeah, you got it. Yeah, she's pointing at the potty. Okay, now what was the cognition? What was the cognition that mom was trying to get in her head? Anyone got it? Anyone catch it? She said it a lot. What was the cognition that, yeah, I got it, her. Tell mommy when you need to pee, right, April? Yeah, that was it. Like we talked about with egocentric, getting concrete, repetition, 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 repetition. We call that a mantra. Those of you who have children or who have had young children, like, 2, 3, 4, 5, I can guarantee you that you have done CBT with your child, and I'm going to prove it right this second. Are you ready? Clean up, everybody clean up, clean. There you go. Right. So there you go. All right, take care, Cynthia. Yeah, that's it. You've done it. Okay. Yeah, you didn't think you did it, but that's what you did. You were doing CBT, weren't you? Now, I have an argument that CBT is easier for young kids than for older kids, and I'm going to give you my argument. Dr. Gomez believed in Santa Claus until he was 13 years old. You know what? Here's why I that. When I was about 6 years old, this Santa Claus stuff, man, that doesn't hold water. I don't believe it. So I asked my Theo Jojo. I was raised by my three Theos who are Vietnam Marines. Okay, this is one of my Theo Jojo. So I said again, he smoked like a Marine and he cussed like a Marine. So I said, Theo, I'm 6 years old when this conversation happens. By the way, Theo, can I ask you something? Yeah, what do you want, man? What do you want? Can I ask you a question about Santa? Yeah, but you haven't seen anything you want, kid. Is Santa real? Do you want to fucking know if Santa Claus is real? Yes, sir, I'd like to know. Santa Claus is 1000% real. It's a mile underneath the North Pole surrounded by a squadron of Marines. We call them Kringle Prime. Sounds at the mall, they're decoys. They get capped. Christmas goes on. Area 51 technology gets them around the planet. I'm like, oh my God, Santa's real. Yeah, I am now 13. It is December. I am in junior high. And I tell my friend just what I told you right this second. And he says, that's the dumbest crap ever heard come out of your mouth, dude. Yeah, I don't believe in Santa. I'm 13, so I don't believe in Santa. I'm seeing if you would believe, because I obviously don't. I was 13 years old when I freaking figured out Santa Claus isn't real because he popped the cognition in my brain and it never left till I was 13. Okay, right, Rocio? Yeah. Now, some of you on this call still believe that if you go outside with your hair wet, you will catch pneumonia and die, right? Some of you still believe that, don't you? Right? You still believe that, huh? Right? Some of you still believe that, right, Melina? Some of you still believe if you eat a watermelon seed, it will grow in your belly. Okay, you kind of don't believe it, but why risk it, right? I mean, Melina's like, "Man, no, I'm just not gonna risk it, right? Some of you still believe you have gum and you swallow it, it will stay in your stomach for 20 years, right? Right, Rocio? You still think that, right? Again, you're like, well, let's not risk it, right, Melina? I mean, obviously we're not gonna risk it, right, Jody? And so yeah, that's what you think. So because someone plopped the cognition in your brain and it didn't leave, and it's still you just don't want to risk it, right? Why eat a watermelon seed, right, Jeanette? Come on. And so yeah, Jody, only you put up your nose, it gets stuck there, right, Alma? And so yeah, so actually this is easier to do with younger kids than it is with older kids. Now. TFCBT has so much data on trauma in young kids. We actually are we're not a old child model. We're not a teen model. We were the original name for trauma focused CBT when the first randomized controlled trial was done in 1995 was like PTSD treatment for sexually abused preschoolers and their non-offending caregiver. Doesn't exactly roll off the tongue, but that's what it was named. Because our first 10 years of TFCBT, we didn't work with anybody older than 6. We thought we were going to be a preschool trauma model. Our thought was let's catch this at 4 versus 14, right? I mean, that makes more sense. As the years went on, the 2000s, we started working with elementary kids. The 2000 teens we worked with teens. I was part of some of those studies. Now in the 2020s, we have, I think, 7 transition age studies completed at this point in time with a bunch more in queue. So we're working with 20-year-olds, college kids. And we're just going up the age range. But we were not originally an adolescent model. We were a 3, 4, 5, 6-year-old model and it worked pretty good. Like 10 sessions in and out, done, even shorter than PCIT, right? And so now this has a ton of data behind it, a ton of outcomes, and we still have a lot for our littles because we started there. So the behavior problems go down, the depression goes down, but also we see parents also have improvement, even without them doing their own therapy. Because we know that most of the parents we work with in need therapy, right? Everybody knows most of the parents that are in our systems need therapy, right? Sorry, they need Jesus, but we will take an LCSW till he gets back. And so, but yeah, and so they're not going to do it though. So we actually see that their outcomes, their depression, their PTSD symptoms, all that stuff goes down with nothing. And here's an example of how that works in real time. So, Haley, I no, you don't need to know how to breathe. That's what our session next week's going to be for your daughter, Haley. I know you don't need to know how to relax, Haley, even though you cussed me out at the intake session the other week. But oh my God, Fernanda, Haley, Fernanda needs to know how to breathe. So you're going to pretend, since kids hate the word homework, Haley, that you don't know how to breathe. And Fernanda's going to teach you how to breathe. We call it belly breathing, color breathing, right? And so again, our parents have enough shame. I don't need Haley to say like, yeah, I just like cussed you out like 3 weeks ago and I feel bad about it. Don't need that. So we the backdoor the skills. They come through the child, through the mouths of babes, right? So that's how we get the skills to the parents. Again, keep in mind we're working both with the caregiver and kid. When you're working with this age range, 5 or younger, we're usually working with 80% parent. Again, that study that I mentioned that Dr. Demlinger, one of our developers, did, the silver medal was parent only. And these are 10-year-olds. You can see how more impactful it is for like a 5-year-old or a 4-year-old, right? Now, the model is goes by the practice acronym. It's third, third, third. It's for like a 3-year-old, it would probably be 8 sessions. For like maybe a very complicated 7, 8-year-old, maybe 16. And you were doing stabilization. We do not talk about the trauma at all until we don't like do what we call a narrative until we get to the middle. But as we're going through, we're doing like gradual exposure, a little bit at a time. Like we're saying the word sexual abuse. We're talking about how your body gets really scared. Your little alarm goes off in your brain when you've seen a trauma, like your mom getting hit by your dad. Okay? And then, like, the last part is we're doing a lot of, like, if they have phobias, we're desensitizing them to them if we haven't already. A lot of conjoint work with the caregiver and kid, and then we're making sure safety is stabilized. This is what it looks like for kids like with IDD, kids, if you got like a young 5-year-old, young 4-year-old, this is what it looks like. It's a lot more phase one, what we call prac. And about instead of third, 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 it's half, quarter, quarter. And you may be going up to 25 sessions, which we think is still not that awful for like a 5-year-old who was sexually abused for a year. I think that's pretty good. And so my colleagues over at the Trauma IDD work group, Dr. Hoover and Dr. D'Amico, developed the new algorithm for kids where they are not neurotypical, because I work a lot with kids with like autism and trauma at like 4 or 5 years old. Now, this is what it looks like if you don't if you work with this population, I would get this book. This is also a good differential, meaning if if for example that Elvira got this book and she said, "Hey, Lopez, does that book match the 4-year-old that you're working with?" No, this doesn't make any sense for my 4-year-old, Michael. Then you might want to do CPP or PCIT instead of TFCBT. Versus, hey, Elvira, does this fit your 4-year-old? Yeah, this is exactly what this kid needs. Thanks for giving me that. And so to show you where that's at, because everything's on Amazon. Uh, like here's what it is. I'll put this link in the chat box for you. And we're just all a slave to Amazon at this point. But here's what the actual manual looks like. So come in here. I just give like a fifth of my income to Amazon every week, honestly. Just like that buy it now button, man. It's dangerous and online, man. Like, yeah, I think I need 4,000 thumbtacks. That sounds about right. Uh, it's good to me, man. Yeah, just 3 a.m. I need some thumbtacks, right? So this is the whole thing. Session 1 to 12 is probably more like 9 or 10 sessions if you only have one trauma. This is it. Psychoeducation, dealing with behavior, feelings, coping, and you're in your story, and then you're out. This has the measures, has the cheat sheets, has the diagrams. One stop shop. Wham, bam. Thank you, therapist. We're all done. In and out. Again, you can see why we started working with like 3, 4, 5-year-olds rather than 17-year-olds, because 17-year-olds take longer, they're more complicated, and you can't just tell them you will eat a watermelon seed and it'll grow in your belly. They won't believe that if they've never heard that before, because that is ridiculous. But some of y'all, why risk it, right? I mean, why risk it, Melina? I mean, let's just play it safe. I mean, lettuce gets us. Let's not even test the watermelon seed, right, Melina? I mean, if the lettuce is coming after us, then let's just do this, okay? Yes, Mercedes, I would highly advise you to get this. This is actually a time capsule. This is what the model looked like circa 95, 96, and it's still very good for our young kids. Now, to that point, to Mercedes' point, we're going to take a trip to Oklahoma, and I promise you it will be more fun than it sounds right now. Okay. So, for those of you interested in TFCBT, there's tfcbt.org. If you need to find a therapist, you go to tfcbt.org, find a therapist. This is also have some really good resources here. But the one I want to show you, especially if you involve, if you do any type of therapeutics or involved in that role at all, case manager, advocate, anything, Oklahoma TFCBT, come here, the resources. Click on that. There we go. And this is our one-stop shop. We have, this is what we used to put this on a flash drive when I was at Oklahoma. Now we just put it here. If you need an assessment measure to screen trauma, there it is. If you need something for a young, this goes down. This is Dr. Sharinga's. This goes down 1 to 6. Young child PTSD checklist. Pretty good. You need stuff on psychoeducation. What do you need, Mercedes? Do you need TFCBT, sexual abuse, grief and loss, DV, complex trauma, neglect, the parenting stuff, right? Here's like labeled praise worksheets, behavior plans, developmental education is what's lying, IDD, relaxation, affect. We have a lot of tools here. So like, and they're much we do kind of skew for this age range. So like for example, the I can relax images like lemon squeezers, the turtle, the muscle man, and you have the script here. This is the actual script for what I just showed you. We have a bunch of other stuff like the pirate script. Um, you may have figured out that trauma-focused CBT is about fidelity to the model. Fidelity to the model is by far the most important thing for trauma-focused CBT when you are implementing it. So to do the pirate script to fidelity, you have to do the voice. Emily, you are the strongest, most famous pirate on the seven seas, Emily, and you've just returned from long months on the ocean, sailing and sailing in search of ancient hidden treasure, Emily. Um, don't ask like another trainer or Dr. Manarino, Cohen or Dale. Don't ask them. Just trust me. It's a science thing. You got to do the voice. It's a science stuff. That's what you got to do. Just try. You don't even ask anybody else. Okay. Um, you want to know what a trauma narrative looks like for a 3-year-old? All right. Yeah, Evan. Thank you, Chelsea. Evan, fire. Cool. So this is what we use for our littles foster group. Ready? When Chelsea was little, she lived with her mother. Their house was in Encino. Draws a picture of her house. Chelsea liked mom's desserts. Chelsea did not like mom's boyfriends. Chelsea felt sad in her old house. One day, Chelsea moved to a new house. She moved because her mother was hurting her. Child welfare moved Chelsea from her old house to her new house. When Chelsea moved, she felt scared. When Chelsea moved, she thought, I'll never see my mom again. If even at like 3 or 4 or 5, if Chelsea has multiple moves, which I've had for my foster kids who are that age, we do it again. Then one day, Chelsea moved to a new house. She moved because her foster dad was hurting her. Child welfare moved Chelsea from her old house to a new house. When Chelsea moved, she felt mad. When Chelsea moved, she thought, why do I have to leave when I didn't do anything wrong? And we can do it again if we want to. Now, Chelsea lives with Miss Cervantes, her foster mom. They're up right, Tia. Their house is in East LA. Draws a picture of Elizabeth's house. Chelsea likes Miss Elizabeth's desserts. Chelsea does not like when Miss Elizabeth smokes. Chelsea feels happy in her new house. Right now, Chelsea's mom and dad are in jail. When Chelsea thinks about her mom and dad, she feels sad. Sometimes Chelsea misses her toys. Chelsea doesn't know yet where her forever home will be. That makes her feel scared. When Chelsea feels scared, she can talk to Miss Mercedes, her therapist. When Chelsea feels scared, she can do something she likes, like play with Miss Elizabeth's dogs. When Chelsea does something she likes, she feels happy. The end. Isn't that sweet? All right. There we go. That yeah, we use that. Yeah, yeah, like Tia, I have kids with like multiple homes, right? So we can do this. We can do this with young kids, and we can do it very easily. Now, Dr. Joyasovsky, one of our big dogs who works a lot with our littles, love her phrase, kids show stress, but they also show resilience. Now, again, there are tons of other resources. The only other ones I wanted to highlight on this webpage is when you get here, we have stuff on sexual behavior problems, like things like private part roles, right there. So if you're dealing with that, there's a whole other thing, okay, not okay touch, safety plans for that. We call the turtle steps, more resources. We also have specific things for Spanish language and specific things for early childhood, right? And so, like the young child workbook I showed you, the Feel Better plan, like the Feeling ID. I'll show you. This one is actually not in this section, but one that Miss Amanda Mittens, our coordinator for child trauma services over at OU, developed. She Oh, sorry, it's an affect. We had a 5-year-old actually want to do Taylor Swift feelings faces, which was very adorable. I thought that was so cute. I have some teen girls who like this one. Uh, as you can tell, I'm not like a Taylor Swift. I'm not a like Taylor Swift person. I'm not a Swiftie. But I have some teen girls who like Taylor, and but I think we can all agree that Red was her breakout album. And obviously 1989 is where she kind of got up to speed. She kind of broke out of like the country mold and got into her kind of own voice. But obviously like what people don't talk about with Taylor, if you're not aware, is like her duets, like with Lana Del Rey, Snow on the Beach, so beautiful. Also like the National Bon Iver, like Aldecott, that's just peak National, and Tay Tay. But again, I don't know a lot about Taylor, just a little bit. And so, yes, Karma is a cat, and that is right, April. And so, now, very last thing, and then we'll go to any questions I did not get. And so, first, I'm going to give you my philosophy of therapy, which I probably should have done earlier. Yeah, right in this year, young kids with signs of trauma relate to the first days of school in the U.S., like going back to shelters. Yeah, it can be triggering. So the quickest way I can do my philosophy of therapy in less than 15 minutes is the following. I was asked by one of the school counselors here in West Texas in the side of Lubbock, East Lubbock, where I grew up at. For some reason, the east side is never the great side, and that's where I grew up at. But I like East Lubbock. I like, well, like East LA too, man. Feel at home there, like feels like El Paso. And so, just like, I don't know, maybe that's me, maybe I'm weird. But so she said, Dr. Gomez, we need a Hispanic doctor to talk to the fifth graders for Hispanic Heritage Month. And I said, I'm not that kind of doctor. And she goes, they're freaking fifth graders. They don't know. I'm like, "Oh, okay, I guess I'll go." And so I thought it was going to be a fifth grade classroom. It was two fifth grade classrooms in a gym. And I followed a firefighter. Guy's like, I save lives. And I'm like, stress balls and feelings. Yay. I was like, okay, well, they're not ED fifth graders, so I think I can do this. So I say I'm a therapist a lot. So I go through, say, I'm a therapist, I do therapy, I'm a therapist. I say it a lot to these fifth graders. Then I say, all right, any questions, anyone? A little shark cookie in the front row. Hmm. I got a question, I got a question, I got a question. What's your question? What's a therapist? How do you explain a therapist to a 10-year-old? I had nothing, but I had nothing. I was like, okay, you can't say, well, you got to go graduate from undergrad and then you take the GRE and then you got to go to an APA accredited pro. You can't say that to a fifth grader. And I had nothing. So I pulled something out of thin air. And from that moment since, it's become my philosophy of therapy. So I said, all right, who here has seen Dumbo? By the way, I think it was when the live action Dumbo came out, because almost every kid had seen Dumbo. I said, oh, thank you, Denise. That's very kind. It takes a lot of trauma to be this funny, Denise, just in case you're wondering. So I said, who's here seen Dumbo? All the kids, I've seen Dumbo. And I pointed to the little girl, loud enough where everyone in the gym can hear it. Can you tell everybody what is the feather? What is the feather in Dumbo? And she goes, well, in Dumbo's friend gives him a magic feather that helps him fly. But his best friend's a liar, doesn't help him fly, just thought he needed to fly. He could fly without the feather the whole time. He didn't need the feather. His friend lied to him. He could fly without the feather. He didn't really need it. It's a therapist. But we are. Didn't need me, Dumbo. Fly the whole time without me. Maybe to get off the ground that first time or two. I don't buy it, but I'll give you that. But no, you didn't need me. You never did. I am not the magic. You are the magic. I'm just a feather. I really, really do believe that. And I thank you, Holly. Appreciate that. And so, may not be apparent from our short interaction today, but outside of this job, I am Matthew McConaughey, True Detective, Season 1. Time is a flat circle, Selena, and we are a misstep in evolution. Okay. I'm a nihilist. I think we're doomed. I'm glad that we're doomed. We messed up everything, and I think good that like cool. I think penguins should be next in line. Okay, because here's my argument. First, no infidelity. That solves a lot of problems. Second, no nuclear war because they don't have opposable thumbs to launch the nukes. There, I think that's a good plan. Penguins should get the next hit. They have a little hat and a briefcase. Doesn't that sound adorable? Yeah, humans are awful. I think they're just awful. That's why I work with teenagers mostly, because I'll tell my teens, they'll be like, people suck. Yeah, people suck. And Yeah, I'm like, cool. And like that, they enhance my worldview. But I have, especially my littles, I have a lot of littles, not all of them, but there is a sizable minority. I have an 8-year-old kid right this second who has been through years of like neglect and sexual trauma and awful, horrible things that people, his parents have done to him. And he's like, I still think people are good. No, people are not good. People are awful, man. Not all of them, most of them. And and this little tiny boy is like, well, I still think they're good. I'm like, crap. Because what he put, the position this little guy put me in is like, all right, man, if you're gonna show up to the fight, how can I do any less? I'm not gonna leave you solo, man. I got your back 10 out of 10 times. Fine. I'll show up for humanity, I guess. Because that little kid shows up. He still believes. By the way, the kids I work with are the only reason I think we have a shot as a species. I really do like they have so much hope and they not all of them obviously. I was one of those kids. Come from a crap ton of trauma. I was not one of those kids, but I have so many that believe that they can we can win, we can do it. We're good. There's good in us. I'm like, God, how do you do that, man? You're 8. Like, how do you do that? Like, I got a PhD, man. I can't believe that crap, man. Like, all right, man, fine. You're showing up to fight. How can I do any less, my friend? All right, fine. I will show up, I guess. Like, not happy about it. I'm not happy about it, but I will do it, I guess. And so that's why I think we got a shot. And that is my philosophy of therapy. Very last thing, then we'll open up for any questions. Michelle will catch that I didn't get. We talked a lot about like evidence-based treatments and practices and like specifics of things like PCIT, but I'm going to give you the most powerful therapy tool I've ever seen. This is the thing to use when you don't know what's happening, like the parent like threw something at you, the kid's doing something, you have no idea what to do, you're up against the wall and you are panicking and you need to break glass in case of emergency. Is everybody ready for the most powerful therapy tool I've ever seen? Ready? Here's what it is. This is it. That was like 10 seconds of silence. It was killing some of you, right? Yeah. It's not what you say, it's often what you don't say. At the end of every protocol I do DBT, I do PCI2, I do TFCBT, I do a lot of other stuff. I will ask, and I do take the feedback very seriously. I'll ask the family what was helpful, what worked, what was the thing that was effective in our therapy. Here's what I want to hear, and I've never heard it, and I never will hear it. I want to say, Dr. Gomez, in session 20, when you did that Socratic questioning and you did the cognitive triangle, I want to hear that. Here's what I hear from across the age range, from my littles to my adults. Like, yo, Dr. Gomez, man, you kept it real, man. No, I was keeping it real in high school. Man, I didn't need to go to grad school, get a PhD and 6 figures of student loan debt to keep. I was keeping it real in the 90s, man. New answer, different answer. I want a different. It's always something like that. It's like, I could trust you. You didn't judge me. Like, no, I was doing that crap back in 95, man. I didn't need to go to like get all the student loan debt and go to grad school and move out to Texas and then come back to it. I didn't need, it's like new answer, new answer. But that's really it. Is that like I think Maya Angelou quote, people don't remember what you say, they remember how you made them feel. That's it. Being present, just being there. That's what they're gonna take away. And the very, very last thing I'll say, then I'll pass it to Michelle and then see if I missed any questions, Michelle, is I am a product of the National Child Traumatic Stress Network. I came up within the network. I'm very proud to be associated with the NCTSN. I'm a product of, the network, and I'm proud of that fact. We, and I have tried more than once, we can train you in damn near anything given enough time, resources, and dedication from you. Denara wants to learn PCIT. We can train you in that, Andrade. Like, you know, Irene wants to learn CPP. Yeah, we got your back. I'll get you with Donna Potter. You'll be good. Lori wants to learn TFCBT. All right, Anderson, got you. Give me a couple months. We can trade. Like, you want to learn how to like work on autism and trauma. You want to learn problematic sexual behaviors. We can do that. There is one thing, and I've tried more than once. All my colleagues have tried at least once that we cannot train you in, and it's the only thing. Oh, National Child Traumatic Stress Network, Patty, NCTSN, and I'll put that in the chat box in a second too. There's one thing we cannot train you in. We've all tried and we've all failed miserably, and none of us have ever succeeded. None of us ever will succeed. Here's the one thing we cannot train you in: to give a crap. Just can't. It's the one thing we can't train you in. So as long as you got that, and my suspicion by being here on this webinar today, and by doing the work you do for as long as you've done it, I think you got that. Everything else is window dressing. Everything else we can train you up in. It's the only thing we can't. So I just want to thank y'all for being here today. I know it's a lot of information. Like Michelle and Lana over at CalTrin will get y'all set up. And obviously, the very last thing I want to make sure to leave y'all with, if anyone, before anyone has any questions, is two things. Ready? Do you know what is the greatest gift anyone can receive in his or her lifetime? The greatest gift we can receive is to have the chance just once in our lives to make a difference. Does everybody know how many times they've made a difference already? Not for 100 lifetimes. Dr. Strange speaking to Peter Parker. Whatever difference you think you need to make, you made it. I promise you that. And you will continue to make it should you choose. So thank you for that.